Thank you very much, Senator McCutchen, and committee. It's great to be with you. I'm going to start and tell you a little bit about the problem, which I don't think I need to go too much in detail in. I think we all realize the challenge with Medicaid funding. Of course, last year we had over $700 million deficit led to the provider fee, med tax, whatever you want to call it. Going forward, the Affordable Care Act implementation may cost us another $100 million. I'm going to focus a little bit on long-term care, that portion of Medicaid, something not a lot of people like to talk about. We mostly talk about the low-income population, and the age wave is about to hit us when the baby boomers are aging. Right now we have 142,000 people over the age of 85 in Georgia. Through the next 30 or 40 years, that's going to quadruple. And we have the third fastest rate of growth in that population, and that's exactly who's going to be needing long-term care. We also have the fifth highest rate of individuals in nursing homes that rely predominantly on Medicaid. So this is something that Georgia specifically really needs to focus on. Of course, Medicaid in Georgia is very dependent on federal funding. And if you've been paying attention to Washington, they're broke, and at some point that funding may go down. And as an entitlement, as you know, with the budget, we've got to fund that first here in Georgia, and that's crowding out other important priorities like education, transportation, and many other things the state could be investing in. And finally, we need to make sure that we're actually serving the population that we want to serve, our most needy individuals in our state. You look at the Oregon study that looked at Medicaid recipients versus the uninsured over the last 3 years and found, surprisingly, there was no significant difference in health outcomes. There are a lot of people who have been battling over the results of that study, but we're spending all this money. We certainly need to make sure that we really are leading to better health outcomes of the people we're trying to help. We think it's a good time before the age wave hits to look at this issue. And we think there's some good opportunities with some states that have done some innovative things that we're going to talk about. First, on long-term care, the problem is for people over 65, there's about a 70% chance that you're going to need some form of long-term care. But not very many people plan or save for this cost or buy insurance to protect them from that risk. Most people, in fact, think that Medicare pays for nursing homes, which in fact it does not, and that it's actually Medicaid, which is a state and federal program. One of the problems we've had with having flexibility is the Affordable Care Act had a maintenance of effort requirement that capped eligibility. You can't make any changes to eligibility. So if you can't adjust eligibility, you really only have two options, and neither one of them are very good. You can reduce benefits, which Georgia already is about the bottom of the optional benefits that you can reduce, and most of those, if you look at them, are probably going to be counterproductive. It's going to cost you more money in the long run if you take those benefits away. And second, you can cut provider payments. Of course, this is something government can do. You can't go to Home Depot and I don't like the price of that ladder, $100, I just want to pay you $50. But we already in Georgia, for nursing homes and long-term care, have below average reimbursement rates. And again, that can be counterproductive if you have providers that pull out of the program. So we've got to decide what we want to do with long-term care. It is designed to be a means-tested program to help the poor and our most vulnerable populations, but there are lots of loopholes right now. And that means that, one, we're crowding out private funding that might be there because people think that they're not going to have to pay for these expenses. And second, studies have shown that the wealthy actually are getting a lot of benefit out of this program. And I don't think that was the intent of the program. So tightening up eligibility, which will be allowed next year, is something that we would encourage the state to look at. Second is the state recovery. We are going to allow people to shelter all these assets. It's fair, it's not a tax, it's just going back after the fact, and if they have sheltered these assets, getting some sort of compensation for the cost that the state has borne for the program. Now, the problem in Georgia, we exempt the first $25,000 of assets. And if you look at states that have been most successful with their state recoveries, the average recoveries are less than $25,000. It doesn't seem like a lot of money, but from a lot of individuals, it can really add up. So that's an option for us to look at what these other states are doing. And finally, if you address these loopholes, we can encourage more private funding. We have a below average participation rate in long-term care insurance in Georgia. We need to promote that program more. And if we eliminate some of these loopholes, for example, right now you're allowed to keep $536,000 in equity in your home, which is a lot of money, and that's where a lot of people have their savings. Absent this readily available government program, people might use reverse mortgages and other ways of tapping into some personal responsibility and their own resources before they have to rely on government if they ever do. So we think that we really need to close those loopholes and really focus the benefits on the poor that really need this program. Finally, focusing on the broader Medicaid program, several of you were at our conference last week where we brought in some experts from around the country to talk about patient-centered Medicaid reform. This is being done in Florida, Kansas, Louisiana, and it's being debated now in North Carolina. Georgia has already implemented some of these reforms, but I think we can learn from these states. Here's some examples of what these states are doing. They have much broader choice. Patients have a choice of 4 or more plans, even in rural areas. Patients get counselors to help them make those decisions. Healthcare is very complicated, and they are assigned somewhat a case manager to make sure they get their services. At our conference, we had a triple amputee who, he said, in the old Medicaid, he would sit at home in a dark room, he wouldn't answer phone calls, he was just depressed. Where the new Medicaid, the case manager was so persistent, she came to his house and got him fitted with prosthetics, and it's a great story. Now he's training to be a member of the Paralympic cycling team. He wants to get off Medicaid. Those are not going to be possible always, but that's the kind of thing you want to encourage. They allow specialty plans that focus on specific conditions and populations so they can truly meet the needs of the patients, personalize the plan. So it might be a mental health care issue that is the issue, or someone with AIDS, HIV. Patients can buy private coverage. There are a lot of different networks, provider service networks that are run by hospitals, physicians, or federally qualified health centers are allowed. In terms of access, the plans are allowed to offer richer optional benefits. They feel like that's going to be more effective. They can waive copays if they want to for their patients. The focus is on better health. The plans can provide benefits like respite care and over-the-counter pharmacy benefits. Patients can get cash incentives for healthy behavior, and that's built into the capitated rates. And the plans can get more money for enrolling sick patients and making them well because they have risk-adjusted rates. And finally, they're incentivized to provide holistic care. There are no carve-outs in these plans, so that when you're dealing with someone with heart disease and they're constantly showing up in the emergency room, it may be because they're suffering from depression as well. But if you separate the mental health from the physical health, you can't do a good job of managing. Finally, what would the cost savings be? They run from anywhere from 3% to about 15%. Louisiana believes they're going to save about 3%, and Florida believes they can save up to 15%. For Georgia, that's anywhere from $250 billion to $1.3 billion. That's total funds, so that's federal and state. That's a fairly significant amount of money. So we have 2 studies. We have 2 studies that we're working on that will be coming out before the end of the year with more specific recommendations on both the areas of long-term care and patient-centered Medicaid reform. But those are the areas where we think we have some opportunities. I'd be happy to answer any questions.
Are there questions from the committee?
I've got a couple, Kelly. Page 6 of your handout, you give examples of the reforms in other states. You did indicate that Georgia has implemented some of these, but right now, the non-aged, blind, and disabled population are enrolled in risk-bearing entities that to my reading, do some of this stuff. They do try to reduce costs. They're supposed to be theoretically responsible for physical, mental, and behavioral health. Some people question that. They're full risk bearing. They get paid a capitated rate. But there's nothing in Georgia that would keep a accountable care organization being formed by a provider network or provider service network that would go out and get an insurance license and put up the capital of the Department of Insurance and essentially become a risk-bearing entity that could then go bid for the Medicaid business to compete with the CMOs, correct? There's nothing to keep that from happening now, is there?
Not that I know of.
Okay.
And I'm curious to find out, that's part of what the study is going to look at, why that hasn't happened. Are there certain regulations, or is it just the fear of the risk? Because you think that provider organizations, I've talked to those in Florida, feel like they could be more efficient without some of the overhead that the CMOs.
I agree with you because you're not dealing with a third party. And the only other question I had is on page 7, the cost-saving projections. When Florida, North Carolina, Kansas, and Louisiana achieved these, did they go from what we used to call or still have traditional Medicaid in Georgia to managed care, or is this applying the percentage savings to the post-CMO budget for Georgia Medicaid?
This is savings to the state with the capitated rates, so that over time you have a predictable increase in cost, and I believe that that's where the savings are coming from. The CMOs are fully capitated and are able to, they are going to make their money on making the patients healthier. Hopefully you have a true focus on managed care instead of just managed cost.
And I couldn't agree with you more. The question I had was, since a large part of the Medicaid population is already capitated, would you really expect to see 10 to 15% or 3 to 4% or 5%?
That's what our study is going to be looking at in more depth.
All right. Thank you.
Any other questions from the committee? Yes.
Kelly, I'd like to know, have you guys looked at fraud and waste in Medicaid? Have you looked at fraud and waste in Medicaid and what's being done to mitigate that? Because that's a problem, and I know that the federal funds have been sharply reduced to investigate that, even though the investigators more than paid their salaries with what they were able to save and get back in fines and that kind of thing. Does Georgia do any of that, or have you looked at it?
No, we have not looked at that, although I think that Georgia is doing a much better job. We're not New York or Florida, where it is rampant. And a lot of that is Medicare, but Medicaid, there is some fraud. We haven't looked at it. Of course, that's always, everyone wants to find savings with fraud. It never seems to appear. But I think the Attorney General's office and DCH I feel like they're working better together to identify. There have been a lot of prosecutions of Medicaid fraud in the last few years, so we have not looked at that, but it just anecdotally, it looks like we're doing a better job in Georgia.
Thank you.
Yes, Senator C.
Thank you, Mr. Chairman. From the onset, you mentioned an Oregon study that didn't give the outcomes looking for. Can you help me understand what those outcomes you were looking for?
Improved health. They looked at, I'm not a doctor, HCV1, hemoglobin levels for diabetes patients, looked at other individuals with chronic disease, other wellness, measures. There's been a tremendous, if you would Google Oregon Health Study, there's a tremendous amount of argument in the policy community and a lot that's been written about the results. The first year of the study, it looked like the Medicare results were much better, and then after 3 years, the data was worse, where there wasn't really much of a difference between the uninsured and the Medicaid population as a whole. There are differences, of course, within. That's why I said, it's controversial. There's been lots of debate. But I think that just causes us, the point I want to make is, we're spending all this money, and it's costing resources that could be going into other state priorities. We need to make sure that we're doing the best job. Sometimes, because of rules and regulations, we don't make the best choices for the patient. And we need to make sure that we're giving the caregivers enough flexibility so that they can make the right decisions. So, this one individual, if she was checking off the box that she was required to try to contact the disabled individuals, she could have called Moyes, 15 times and said, okay, well, we tried. But she went the extra step to go to his house and talk to him, and he dramatically reduced his hospital expenses. He hasn't been in the emergency room in 2 years now because he's improved his health. Well, that's good for everybody. And we want to encourage, have those incentives in place rather than a more bureaucratic perspective on just checking off the boxes, like a lot of the disease management companies. You know, everyone's opted in, and they say they send information to people on how they can, you know, do a better job of managing their disease, but it's not really that human touch that you really need. So that's sort of what we're focusing on. Let's make sure we're getting the best outcomes for the money we're spending, because we're certainly spending a lot of money.
And follow up, therefore, all we need to do then is increase what we are expecting for them to do, not just continue to make one phone call or 2 phone calls or 15 phone calls, but you're expecting the next level and the next level. Those type things on the front end will give you the outcomes that you're looking for, would it
And
not?
give them the flexibility, combining, like we talked about, don't separate mental health and physical health. Let's coordinate, because you know, it's a wasted money to, you know, people keep coming back to the emergency rooms if you're not curing the underlying problem.
Other questions from the committee? Yes.
Question? Kelly, have you all taken a look at what Texas has done in the area of managed care for the ABD or long-term care populations? I think it's the Star Plus program that they have. It's been a couple years, I think, in development. They've started it in a couple metropolitan areas, and I believe if they haven't already, they're moving that out to a more statewide type of approach. Will your study do any analysis of that work?
We have not that I'm aware of. I
Okay.
can ask the individuals that are doing that study to take a look at Texas and
Okay.
include that.
Any other questions? When you referred earlier to sheltering assets, you're talking about the Medicaid liens to be able to...
Miller Trust, you know, the exemption for $536,000 of home equity, the unlimited amounts of certain excluded assets like cars and vehicles and other things that you can buy. I think there's some abuse of those rules, and I understand the point. But, you know, I think if you ask anyone what they want our Medicaid program to do, we want to take care of our most vulnerable members of our population. It should not be a middle class or an upper income entitlement program. And to a certain extent, that's what it's becoming. And for those that take advantage of those legal opportunities, it's unfair for those that are taking personal responsibility and paying for an assisted living home and paying out of their own pocket for personal nurse care and those sorts of things.
And you referred to $25,000 exemption, just off the top of your head. I mean, the other states that you're sort of looking at, do they have no exemption, or is it a lower exemption, or do you know?
I don't know the details of that. I'd be happy to have the person that's the author of our study that's going to be published in 2 or 3 weeks on the long-term care to come testify at your next meeting.
Okay,
Give all of
that'd
those.
be great. Thank you. Any other questions? Thank you very much. I appreciate it.